Welcome, everybody.
Nice turnout.
Not bad, not bad. Welcome, everybody, and please help yourselves to the refreshments. But today's a special day. We're welcoming back a prodigal daughter, if such a thing exists. But Jan is a dear friend and one of the pioneers in the creation of the School of Public Health. She was with us in the Department of Epidemiology and Biostatistics, and at that time also jointly in the Institute of Demography at the Baruch College. She was one of a few faculty, Shiro was the other faculty who was joined between us and between Baruch, but I will say that at that time, I was the dean of the consortial school, and I could not have expected her to do more for Epi and Biostat, although she was there only 50%. But she was fully engaged with our students and other faculty, a great team player, and she was snatched away from us by a successful career of her wonderful spouse, who is a very prominent financier. She smiles when I say that. And both of them, off they went with their three lovely children to London. She started at London University in King's College, but obviously gained prominence in the English scene very quickly with her acumen, her well-disguised nerdiness in the form of a true lady. But soon enough, she moved from King's College to Oxford, where she's currently the deputy director of the Leverhulme Centre for Demographic Science at the University of Oxford. And as we know, she is trained as a demographer. She has training in economics and epidemiology, and earned her PhD at Princeton University and a postdoctoral fellowship at Robert Wood Johnson. She really focuses on statistical analysis of large data sets, and I know that Mary Schooling here, who's busy reading something, is another one of those prominent scientists in our school who has focused her career on large data sets and directed her research towards population health outcomes. And they had that in common. And another thing they have in common, obviously, is the British connection. But other than that, Jennifer has really been a pioneer in starting new groups of people. The Nerdy Girls, for example, is one of the groups that she has started, a group of researchers who are interested in mathematical and statistical sciences in different ways, and interestingly enough has intersected with our current faculty in different intersectionalities that she has, worked with Rachel at some point, or met Rachel and intersected with her, worked with Mustafa, and so even some of our newer faculty got to know her in her different roles. And interdisciplinary perspective has always been her goal, and especially valuable for Jen's work in COVID-19. And I think she's going to focus some of her presentation today in A Tale of Two Countries on a comparison of her adopted country and her country where her heart resides. And so we are very, very happy to see her join us. It's been long in the coming. Jen and I have been trying to make this happen for a while now, and we're very happy that she's finally come back to CUNY School of Public Health, met some of you, and we hope this will be an entree to more connections and more collaboration in the future with many of her old colleagues like Dennis and some of her new colleagues like Rachel and Mustafa and Jeff and others and Scott, many who have met her already and are interested in creating new bridges with her. So please give the heartiest of welcomes to a dear friend and colleague, Jen Dowd. We're very excited to have you with us today.
That was the nicest introduction I've ever gotten. Thank you. It does feel like coming home. No, I'm really, really grateful to be here. It's so great to see all these familiar faces and then people I did know in other realms who have made their way to CUNY, which is amazing. You guys continue to attract the best talent. It's really special to be back. For those of you who don't know, I arrived here at the Brookdale campus in 2008 in this joint demography and school public health position. And so it was just the beginning baby steps towards what has, grown into this amazing school public health. And it has been just so gratifying to see from afar what you guys have done since I've left. Just the prominence and impact of the CUNY SPH is really noticeable, even from overseas. And it was especially exciting to see during the pandemic, all of the work of the school kind of stepping up and filling the needs of New York City, especially, but also globally. And so I was really proud as, I guess, an faculty alum, to see that happening. And so, yes, it's been a great visit, and I really hope that we can reconnect and build some collaborations and invite some of you guys across the pond as well. So yes, given that a lot of you I know worked very intensely on the pandemic, I think Ayman thought this would be a good topic. And I'm going to give an overview of how COVID mostly impacted mortality in the US and the UK, which are, yes, two countries close to my heart. Now I have officially dual citizenship, so, but my loyalty is to the US, so I'll be clear. So there were some very interesting similarities and differences in how the pandemic played out across the two countries. And, it's very difficult to pinpoint specific things that made outcomes different in a very causal way, but I have some theories of what things were important. And, I'll just say this presentation is very much my experience of working on COVID and, the little niche that I was doing, but I recognize that so many people here were working on different facets of COVID and, the pandemic impact and how we, what we're learning to prevent future pandemics. So I really wish I could kind of sit here and debrief for hours with all of you, kind of all angles of the pandemic. And we did a little bit at lunch yesterday. I feel like there's some collective therapy that public health people actually still need to do to process that. But I'll, kind of give you a little slice of what I was up to. And then hopefully we'll have time for discussion and to hear more from you guys. Let me get that going. All right. So I'm going to kind of give this through the lens of demography, since I had just started at a new demography center in November of 2019, and that's some of my training. So there'll be a bit of a thread of how kind of population level thinking, I think, ended up being really important for the pandemic. And I'll summarize some of these trends in mortality in the US and UK, and kind of end with thinking more broadly about where mortality and population health are going post-pandemic. And there will be some memes in there as well. But I want to take you back, I guess, to February and March of 2020, which I know is probably emblazoned in a lot of your minds. But like many of you, I was following with interest the COVID news early in the year, and it kind of, seemed distant and in the realm of, it was something for the virologists to be thinking about. But I think it quickly became clear to all of us that this was going to be a crisis relevant to all of us, both personally and professionally. And for me, this happened while the virus started really taking off in Italy. We had two postdocs who were in our center and had gone home and were under lockdown in the Lombardy region and kind of sending us updates at that time. And of course, Italy was the first place outside of Wuhan to really start seeing high levels of mortality. So, it was a question of whether this would, we would see such bad mortality outside of that original context. And some gratitude here to the Statistical Public Health Agency in Italy. They started releasing daily fatality data broken down by age, which was key for us. And I think as demographers, looking at this type of data, so it's a little bit cut off, but that's age, obviously. And then these are, I'm trying to look at this on my thing, but in the final column, it's the case fatality rates, which would be the percent who die who have a recorded infection. And so we know that the denominator for this type of data, especially early on, was not great because we had no idea how many people were infected. These were probably people being hospitalized and tested. But one important thing, even if we think the denominators were not quite right, that was very obvious was the age distribution of deaths that we were seeing. So very concentrated above age 60. Only 5% of deaths were being seen under age 60. And all of this kind of raw data that was coming out was just really important because we were trying to get a handle, if you can remember, on how lethal is this new pathogen. And it was a really important question because decisions that we were going to make about closing down schools or other major societal restrictions really depended on understanding, is this worse than the flu, which became this unfortunate benchmark that kind of never went away. But this data started to show us that this was a very serious pathogen and that age was going to be an important factor. Yeah, so I'm losing the top, but this is a, yeah, that would be over. Yes, thank you guys. That's better because you have to see the memes. Now, this was a tweet from Monica Alexander, who's a great demographer in Toronto. But we learned the day that, so we were thinking about this importance for age and the fact that Italy is, one of the second oldest country in the world after Japan. So it had a very high percentage of its population above age 65. And so we were hypothesizing that this was helping to explain the really high mortality in Italy. And so we put out a preprint on March 15th, and it just, even before, so this was before our preprint, she wasn't responding to us, but it was kind of comforting to know that all demographers were thinking the same thing, looking at these mortality rates. So it was actually a very basic but important point that was the most demography thing ever. So we took that as a bit of a compliment. Get back on. And so the preprint became a paper that I came out, things were accelerated. So I think it came out in April of 2020. But the basic idea was that we created a couple stylized comparisons of populations that were roughly the same size, in this case, Italy and South Korea, but had very different age structures, and kind of assumed a uniform infection rate of 10% and took the case fatality rates by age that we were seeing in Italy at the time, and just illustrated how many more deaths you would expect in countries with older age structures. So a very, very basic point, and you can change some of the assumptions, but this tight association between age and mortality was really the key thing. Our group quickly kind of got contacted by policymakers in the UK and extended this to looking at subnational vulnerability to hospital, hospital capacity and hospital beds by combining NHS hospital data, bed data with age demographics and also deprivation. I think we were all of us at this time were kind of scrambling to understand where the vulnerabilities were going to be before things had spread to other locations. And the other point that we made in that paper that was a demographic point was the idea that the spread to older people in Italy had been accelerated by intergenerational residence. And this is some survey data that just shows the percentage of adults over age 60 who have daily contact with their children. and Italy's kind of on the high end there. US less so. And, there was kind of an entry point in importation of the virus to Milan, but a lot of those young professionals were either commuting out to the more rural areas, living with their families, or going out and dining with their older relatives. And so we hypothesized that accelerated the transmission in Italy. And we got some heat from the Italian press at the time, who said we were blaming the family for the high mortality in Italy, which was not our intention, but we wanted to draw attention to the importance of different demographic factors. And my understanding is this also really played out in New York City in that first wave, and in Queens and places where a lot of the immigrant populations lived in multi-generational households. But getting back to the age distribution, I just wanted to point out how important age adjustment that we all take such for granted in a lot of our certainly epidemiological descriptive work ended up being so important. And this was, early data from New York City that basically showed the percentage of Hispanics who were dying was similar to their overall, population, proportion of the population. And so the point that Usama, who I think is at Drexel, was making was that this raw data would make it seem like there's not a disparity in mortality by race, ethnicity, but because the Hispanic population in New York is so much younger, it's actually obscuring that disparity to not adjust for age. So again, this is such a basic point, but it's kind of worth remembering how we take these basic things for granted, but when a crisis is happening, this data was coming out kind of raw and fast and furious. And those, all of you who have experience kind of looking at this type of data on a daily basis, it was really important for those with that experience to harness those skills and help people interpret what was going on. I'm not saying it was as important as the clinical stuff or the bench science that gave us the vaccines, but I think don't underestimate how important kind of the ability to rapidly interpret this kind of data was during the pandemic. And yeah, one more meme. So you can't just report mortality rates without adjusting for age. And the next area where I think that population demographic perspective was really important, as I said, was trying to continue to get a handle on how deadly this virus was. As I said, that was an early kind of controversy. We had people you might remember, like John Ioannidis and other people at Stanford, really putting out these lowball estimates that made COVID seem not as dangerous or pretty close to the flu. And this, I wanted to shout out to New York City, also Department of Public Health, for releasing amazing data in real time. And this is what I finally realized was kind of indisputable evidence of the severity of COVID relative to the flu, in that these data show the denominator in this case is not everyone who's infected, which is often what we were trying to get, but actually the whole population of New York City. And you could see as of May 8th that 0.23% of the population, the whole population as the denominator, had died COVID. And that, I think it's about 0.1% for the flu of people infected who die. So, and then you can see among 75 and older, it was 1.66% of the entire population in New York City. So to me, this was such a great benefit of having this real-time data and kind of trying to steer away those COVID deniers early, even though that became very, very political. But as the pandemic went on, we started to get better estimates of that infection fatality rate. So how many people who are actually infected might die. And that also came from some very good population-based surveillance data. Spain, as well as the UK, did some very large population representative surveys where they went around and took blood to get seroprevalence estimates, which back then, not many people had been exposed. So you could really just look for the presence of antibodies and get an estimate of how many people have been infected, and then calculate these much more accurate infection fatality rates. And so this was a paper that kind of collated. I was not involved in this, but I thought it was great to bring together that data. And it showed the importance of age, how much the infection fatality went up with age to almost 15% above age 85, but even 4.6%. Again, this is the pre-vaccine era, but this type of population-based data really gave us a handle on how dangerous the infection was, and the groups that we would most need to protect, obviously, as the virus kept spreading. And this also led to us being able to directly compare the fatality rate to flu, which is in the red line. No, influenza is in the blue line, sorry. And I'll just point out that this is on the log scale, so it's actually really big differences. So you can see at the older ages, flu or COVID was 15 to 13 times deadlier than the flu. But even, at younger ages, it was considerably more dangerous to get infected with COVID. So I think this was really important for communicating the severity of the pandemic. And another metric that started evolving that had been very much more common in demography prior to the pandemic, but in very specific cases was excess mortality. And so this was a concept in demography that was often used to measure mortality from natural disasters or something like heat-related deaths, where you're not measuring that cause of death very accurately. So you just look at deaths from all causes and then estimate how many more deaths are you seeing from any cause above and beyond what you would have expected. So excess mortality suddenly became a good way, because we knew that, testing for COVID and having COVID attributed deaths was very, undercounted in a lot of places, and that varied across time and space. So excess mortality could give us a better picture of what was going on. And it became kind of mainstream. This is from the New York Times from the first wave in the US. And what I also liked about this visualization was that you could see how the Northeast was really where the excess mortality was in the first few months, and how it kind of moved regionally in the US as the pandemic kind of made its way geographically outside of the Northeast and the coastal areas. And that was really important because at the time, a lot of people were saying the restrictions and the stay-at-home orders and the lockdowns were what was killing people, right? There was a lot of this rhetoric, and you can actually see it move perfectly with, where cases and where the virus is actually spreading. So it was a very kind of useful tool in that sense. And yes, there was an allusion to Dear Pandemic, or Those Nerdy Girls, which was the science communication platform that I also joined during COVID. And we tried to respond to a lot of misinformation as it was coming out. And this survey is from later in the pandemic, but one of the top kind of myths that people believed was that the government was exaggerating the number of COVID deaths. So you probably remember from, I don't know, saying that people were coming in with motorcycle accidents and being coded as COVID deaths because doctors were getting extra financial incentives for that. So, there was a pretty prominent belief that that was the case. And excess mortality, so I wrote kind of my first post trying to explain excess mortality in July 2020. And it really, I think, intuitively telling people that we don't have to count official COVID deaths. We can just look at how many more deaths we're seeing overall, kind of this counterfactual world without COVID. How many deaths would we expect? And so explaining that in layman's terms, it became one of our, at the time, most widely disseminated posts. And I thought it was a really interesting example of the kind of information that people really wanted. It sort of clicked with people that this is a way to kind of talk to my skeptical uncle or whoever is telling me that we're overestimating COVID deaths, and kind of made me realize the power of some of these metrics that we've used very academically to help kind of bring home the mortality burden of the pandemic to the public. So I think that was something I would never have expected, was to see excess mortality in the New York Times and The Economist and lots of places, just as a routine figure for understanding what was going on. But I was really glad that we had that tool. So excess mortality was kind of a great way to get a handle on this mortality burden, but it's not as easily comparable across countries or across time and space, because obviously larger countries have more excess. It doesn't, completely account for age structure. So as we got more data, our group took a look at how COVID had impacted life expectancy, which again is another favorite metric of demographers. And that was also a lesson in science communication, because life expectancy sounds very intuitive, like it's how long you should expect to live. But when the news came out, I think the first year that life expectancy had dropped by a couple of years in the US, all of the chatter, even in the media, was that, wow, we're all going to live 2 years less now that we've just had this COVID pandemic. And so we realized how, as demographers, this is not a very intuitive method, but it's still the best way that we have to kind of summarize current mortality conditions. So I guess that's the important thing for those of you who haven't, used the life table or calculated life expectancy. It's really a snapshot of all of the age-specific mortality rates in 1 year. And then you're running a pretend, cohort of people from birth all through their lifetime to see what their expected length of life would be under those mortality conditions. So you did not lose 2 years of life expectancy in 2020 just by living in the US. But the people who died obviously lost a lot of many years of remaining expected life that they had. So it has some disadvantages as far as explaining what's going on, but it really is a good way to compare the magnitude of big mortality shocks across time and across countries. So this paper looked at 2020 and 2021 changes in life expectancy, and it's a bit of a involved data visualization. So I'll just point out, these are changes in months in life expectancy compared to 2019. But basically the top part of each line is the loss in 2020 in each country compared to 2019. And then but that's the top part. And then the bottom line is either kind of getting worse in 2021 or rebounding a bit in these blue lines. And I'll zoom in a bit just so you can see that the US was kind of amongst the worst in performance, both in 2020, losing over 2 years of life expectancy, but we actually did worse in 2021, not better. We lost additional life expectancy, and the countries that had similar patterns, as you can see, were all in Eastern Europe, not countries that we generally think of as our peers in health. But that's kind of where we fell in the rankings, unfortunately. And England and Wales is, up at the top there, lost less, so a little under a year of life expectancy in 2020, and actually regained some of that in 2021. So 2021 really led to this big divergence where some countries got worse, and a lot of these European countries managed to rebound and get back to some of their pre-pandemic life expectancies. So that's kind of when you could really see the different policy decisions that were being made. And yes.
These data you got from data that's available?
These were all, that's a good question, from the human mortality database. So they would have been reported by the countries, but that was the limitation on which countries we could look at because you needed high quality data that was in single years of age. And so we did all the countries that had. We analyzed all countries for which the data were available. So they either didn't have it in time or not in the form. Some countries report very broad age groups, which makes it harder. No, it's a great question because the whole aspect of data was a big thing that came out of COVID. But the other thing I wanted to point out about the US that was very different from most other high income countries was the ages contributions to these drops in life expectancy. And so this is from just 2020, but I think the visualization, you can kind of see these are the ages that contributed to life expectancy drops in that teal color. And basically the US was completely unique amongst high income countries in seeing, the majority of losses, under or a lot of losses in life expectancy under age 60. If you, I don't know, compare to a lot of the European countries, let's see, the Netherlands, the deaths, Sweden, things were much more concentrated at older ages. And this was a pattern in 2020, pre-vaccines, but it was a pattern that persisted and even got worse as the pandemic went along. And so this is now going to take stock of excess mortality in the US from the beginning of the pandemic to December of 2022 by specific causes of death. And that's one reason we don't have 2023 yet, because there's kind of delays in registration for causes of death. But I guess I want to point out there's a lot going on here. The kind of peach color would indicate COVID deaths. And all these other colors show other causes of death that were elevated relative to what we would have expected. And the things that really stood out were overall, there were 1.3 million total excess deaths over this period, which was actually more than official COVID deaths. I don't know if I wrote down the exact number, but in the US, there were more excess deaths than official COVID deaths. In the UK, there were actually more official COVID deaths than excess deaths, but I'll dive into that in a bit. But there were over 100,000 excess deaths attributed to cardiovascular disease. And the other really unique features of the US excess mortality were big increases in drug overdose and substance use mortality, which were really not seen in most other high-income countries. And this, as you know, was on top of already very high levels of drug overdose deaths. So it was really, really a tragic thing. And we also found significant increases in traffic accidents. There was actually a drop right in March and April of 2020 when people were off the roads. But shortly after that, traffic accidents mortality went up quite a bit. And we really tried to dig into what was going on. And it seemed was just a lot more risky driving, people out late at night or on emptier roads that they felt like they could go fast. So it was just interesting that it really persisted for a long time in the pandemic. And then the only places where we saw fewer deaths than expected were these other infectious causes. As you know, influenza kind of completely disappeared for a couple seasons. And then the other interesting finding was that deaths due to suicide were less than expected. And we all know this was a big concern about mental health and lockdowns. And this was consistent with what we found in the UK as well, that suicides actually went down. And there's definitely heterogeneity in there by different ages and things. It's not a universal story, but I think that it was interesting that went counter to a lot of people's expectations. Yeah. Yeah, that's a good question. I'm glossing over a lot. It's 2015 to 2019. The models are based on that projects the expected deaths. So very good question. But that gets harder to do the farther you get out, as you can imagine. So now that we're in 2024, what's the counterfactual for no pandemic? That gets a lot harder. And this is just zeroing in on those models. So we're only showing from 2019, but you can kind of see the model fit prior to the pandemic and the seasonality of some of these causes of death, and how you can just really see already we were accounting for this upward trend in deaths due to substance use, but these green dots show what actually happened compared to the expected deaths, and it just really popped up. And you can see that as well for accidents, diabetes, cardiovascular disease, which we'll talk about. And cancer was the other one for which there really was no obvious excess. And I know there were also a lot of concerns about delayed screening and treatment, but that didn't seem to show up, at least in the cancer deaths. But I think there's some questions about whether cancer patients were more likely to die from COVID, which would mean they were less likely to show up a few months later in COVID, in cancer deaths. So that's what the individual causes of death look like. And now I want to show you what this looks like in England and Wales for the same time period. I'll have to get the colors to be the same ultimately, because that's a bit confusing. But basically in the early pandemic was quite severe in England and Wales because, kind of like New York, London got hit very early and very unprepared. Tons of really high mortality, moving older people from hospitals back into care homes without testing, without precautions, just really, really high mortality, like similar to what happened in New York City. And London's a higher kind of proportion of the country. So that made the national statistics really, really bad in 2020. Then you can see that alpha wave that happened in the winter of 2021. But I want you to notice, compared to what happened in the US, where we have July of 2021, everyone who has had some access to vaccines by that point. The US had substantial excess mortality in the Delta and Omicron waves after vaccine rollout that really didn't happen in the UK. And you can see this much more muted mortality, excess mortality after the vaccine rollout in the UK. And I think those things are very closely tied to vaccine take-up, which I'll go through in a bit. But this is when I just, watching both countries very closely the whole time, I was constantly glued to this type of data, and seeing this real divergence after July of 21 was really, really striking to me. And so for the overall US experience through the end of 2022, what really stood out compared to the UK and other high-income countries were these elevations in substance-related deaths, which was really, didn't happen anywhere else. Even Scotland, which actually has really high levels of drug overdose deaths right now, saw a drop during the pandemic, not this increase as in the US. And then these somewhat surprising or unexpected results of no excess from cancer, suicide. So some good news. And then these excess mortality deaths that were attributed to cardiovascular disease, there's been some other work by Andrew Stokes and colleagues at Boston University, really looking at the timing and the local variation in these non-COVID excess deaths. And to me, they've shown pretty convincingly that these were likely undercounted COVID deaths. And you should look at their papers if you're interested in the details, but because there's also counties in the US where undercounting was worse, and that was affiliated with political partisanship, as you can imagine, but you can really see the timing of these excess cardiovascular disease deaths coincide very closely with COVID waves. So we think in the US, a lot of these excess CVD deaths are actually uncounted COVID deaths, which did not happen as much in the UK. And then a really different age profile of deaths in the US compared to other high-income countries with much higher pandemic mortality in younger and working age populations were the really, really distinct patterns. And this kind of shows that different age distribution. These are confirmed COVID deaths, so still subject to undercounting in the US, but you can kind of see the shifting of the age distribution of deaths in the US. A lot more deaths kind of under age 65 compared to what you see in England and Wales. And, you know, that I think is very tied to some of these pre-existing patterns that we saw in US mortality, which if you guys haven't heard the bad news, the US has been falling behind comparable high-income countries. I guess it's debatable what peer countries actually are, but kind of OECD countries, the US's life expectancy has been falling behind and really starting to diverge since 1980. And I think these little gray lines are the other countries. So you could actually say we're completely out of the pack now. We're not even just falling behind. So this was the context, you know, even going into the pandemic of US mortality. And so that is one of the hypotheses about why did the US see so many more deaths and deaths that were shifted younger is this idea of existing health disadvantage in the US. And so there have been some papers directly comparing kind of harmonized biomarker data from, this is from the Health and Retirement Study and ELSA in the UK, ages 55 to 64, so at decent risk for severe COVID. And the US, you know, just consistently had worse health, especially in a lot of these cardiometabolic conditions, diabetes, hypertension, that are, you know, severe, increased your risk of severe COVID. And yes, so this higher US disadvantage is especially true for metabolic and CVD risk, including markers of inflammation, which we think are important for severe COVID. And you can also just see that the BMI distribution is quite shifted to the right in the US compared to England. And England is still, you know, suffering higher levels of obesity than a lot of the rest of Europe, but the US is always kind of ahead of the curve in that respect. So this, you know, is one hypothesis for why the US you know, suffered even in 2020 prior to vaccine rollout, more deaths and more deaths at working ages. But I want to talk a little bit about this vaccine, differences in vaccine policy, since it was also something that I observed with a lot of interest as it was happening. The US and UK took very different approaches to a couple different important vaccine policies. The first was age prioritization, and the second was whether to delay second doses or not, which you guys probably remember all of this. And the first vaccine was given on December 8th to Margaret Keenan in England, the first Pfizer vaccine. So I think if you all put yourselves back in that moment too, it was like, I can't believe these trials came out and were so amazing and we're about to, you know, end the pandemic very quickly. But it was such a moment, you know, of excitement and hope after all that had happened. But we did have this now very important kind of population problem of how to distribute vaccines while supply was limited. And again, I found this a really interesting tension between kind of a more clinical perspective versus a population or public health perspective. And I'll talk a little bit about that. But the US and the UK actually made very different decisions about those two policies. And at the time, there was a very big winter wave rolling out in the UK. So these decisions seemed very important. And in the US, I think ultimately there kind of was a lull in cases during the rollout that made it not as bad as it could have been. But yeah, we can talk about that counterfactual. But this was basically the proposal for vaccine prioritization in the UK, which really did start with people in nursing homes and the people who take care of them. But then it was very strict though in that definition, and then started with 80 and over, and then frontline health and health workers, everyone over age 75. It really marched down very carefully by age, and you really had no way to circumvent your where you were in line, unlike in the US, as I understand. And the reasoning for this was looking at the mortality data in the UK up till then, which was very concentrated at older ages. So the the theory was that you could prevent the most deaths by basically going in really strict age prioritization. And there were also some demography papers coming out at this time trying to inform these decisions that really, I thought, convincingly showed that because it was such a steep relationship between age and mortality for COVID, that age prioritization under most scenarios was going to be the strategy that minimized deaths. Because you could make arguments that younger people are more likely to transmit if they have more contacts. But in various modeling scenarios, this strong relationship with age usually dominated and meant that age prioritization was the mortality minimizing strategy. In the US, as you know, there was a lot of discussion. There was a National Academy panel earlier in 2020 convened to think about vaccine prioritization, and which were used as recommendations for the ACIP ultimate recommendations. And the US focused a lot more, not surprisingly, on occupational exposures, frontline, so not just frontline health workers, but frontline non-healthcare workers, first responders. But you can see the long lists that got into those occupational prioritizations, became a pretty high percentage of the population. And then from a practical standpoint, as I said, in the UK, the NHS would send out invitations that it was your opportunity to get your shot. So there was no circumventing that. And, my experience of talking to everyone I knew in the US was a lot of chaos and older relatives not getting, the vaccine very quickly, but younger people who had some kind of access to a university health center or something, getting it very early, and people really struggling online to help their families and travel for vaccines. So it sounded a lot more chaotic than it was in England. And I think that mattered. And then the second decision that was very different for vaccine policy in the UK was whether to delay second doses. So if you remember the mRNA vaccines, both Pfizer and Moderna, the clinical trials had either 3 weeks or 4 weeks in between the first and second dose. And that's, how they were approved by the FDA, I guess. But, a lot of immunologists thought actually, it might be better to space them out, even, just for immune response, but also one dose looked quite effective at blocking infection in the near term if you looked at the trial data. And so the UK decided, we want to cover, we're in a pandemic, we want to cover as many people with 80% protection as we can by delaying these second doses. And it was, not even that controversial. It was just, seemed like an obvious way to maximize public health benefits. And it was really interesting then to watch the US, because from what I could see, it didn't even become a discussion in these advisory committee meetings. I saw some op-eds. There were some epidemiologists and people suggesting that the US should consider this. But the rhetoric I saw was very much, the clinical trials did these 3 weeks in between. We cannot deviate from the clinical trial. The patients would be upset that they're not getting their second shot after 3 weeks. And that's when it struck me that, so I'd be interested to hear your thoughts, that we need more public health, population-based people on some of these advisory committees, because I can understand the clinical perspective. Most drugs, it is all about the individual benefit when you're making recommendations, but in a pandemic, the questions were very, very different. And I don't think the clinical perspective should have dominated in that case. So I think, yes, we all need to get more active on those types of decisions. And this delayed second dose policy really did lead to much higher coverage at older ages in England compared to the US, as that January through July of 2021 rolled out. You can see the US did better at younger ages because they really didn't give any vaccines to younger people in England until the summer. But this gap really opened up at older ages that were the most vulnerable to COVID deaths. But then you can also see just the difference in ultimate take-up was quite different.
Much higher,
Faster, yeah. Yes, they did it exactly, because they would do 5 age groups at a time, and it was very efficient with the NHS. And I guess people were just very excited and willing to go get their jabs.
Was there any?
About the delaying? Oh, we're not getting them. The politicalization in general, you mean kind of the anti-vax?
Yeah.
Yeah, very little, which I'm going to talk about. It was a big difference. Do you have a question, Ivan?
No, I was saying,
Yeah.
were people upset that they were not getting.
Not much grumbling, because it was just matter of factly, like, this is how it's going to be. And so I found that pretty interesting. It was kind of like Americans demanding their individual benefits. But so that was kind of in the first 6 months of vaccine rollout. I think those 2 policies were important. But as we know, it really mattered in the summer when the Delta variant emerged, and we saw more cases kind of than we'd ever seen with these new, much more transmissible variants. And this is where the differences with the US and the rest of Europe really opened up as far as mortality. And it's very hard to prove with just these types of national level pictures, but the uptake of vaccines in the US compared to those other countries was a lot less. So you can see the red is unvaccinated. And then what I think is really interesting is this blue part here is that 3rd dose, what we called boosters. But if you remember, by the fall of 2021, it was becoming clear that that 3rd dose really should be part of the primary series, and might actually be more important in the US because of the close spacing of the first 2 vaccines, that this 12-week gap. So it was a 12-week gap in England, and a lot of other European countries also stretched that out, kind of led to a better immune response. So the US, not only had lower uptake, but the people who did get it might have gotten it in a way that didn't optimize their immune response. And then the take-up of that 3rd dose was quite low in the midst of this huge Omicron wave that crashed down in that winter. And so this is a visualization from the Financial Times, but they did some counterfactuals of what the US hospitalizations would have been like during that Delta and Omicron waves if they'd had the vaccine coverage of Denmark. So, these are counterfactual scenarios that may or may not be realistic. But I guess I'll just point this out too, what was really interesting being in England, you can see the blue lines of that 3rd dose just go from 0 to almost 100 really quickly. And that was, Boris Johnson, to his credit, just announced everyone in the country is going to get their 3rd dose before Christmas. And it happened in a matter weeks. And because Omicron really crashed in December and January, I think that, really, really made the difference in the US versus UK mortality, showing how many more US folks at older ages were unvaccinated. And as we were alluding to, what's very special about the US is this political polarization of the vaccine uptake. So this is from the Kaiser Family Foundation, and I can't remember when it was taken, but I think it's pretty stable now that Republicans were much, much less likely to report being vaccinated. And that's no surprise to any of you, but it actually showed up in the mortality data.
Did you see difference in the type of vaccine, the mRNA vaccine in the US versus the AstraZeneca that was used?
As far as like mortality or?
The dosing also is different, like you said.
Yes. No, I mean, that's a good point. In the UK, they used a lot of AstraZeneca, which was the Oxford AstraZeneca, which was the adenovirus similar to J&J. But yeah, I mean, I think we had good studies that showed you were more likely to get reinfected with Delta if you'd had that compared to mRNA, but it didn't seem to show up, I guess, that clearly in the national mortality. So I think getting any vaccine was really the key to lowering that mortality risk dramatically. But there's so many interesting differences and nuances to explore. But as I was saying, I think, the tragedy, one of many tragedies in the US during the pandemic was this political polarization of everything in the pandemic, but especially the vaccines. And you could actually see, so this paper, I'm trying to remember the details, but they were able to get kind of individual level voter registration data to have a good handle on partisan affiliation tied to mortality records. Yeah, I'm forgetting the details, but it was a very nice design that really showed this gap opened up after the vaccine rollout in excess mortality by partisanship. And that's just like so awful to think that that type of information and vaccines becoming a political identity, is so visible in the actual mortality data. And as we were getting to, this really was unique in the US compared to Europe as far as differences in vaccine take-up by political partisanship. So you can see the US there on the left, but along the continuum in the UK, really no association, and then kind of much shallower, some correlation in some other countries, but not nearly as strong as we saw in the US. So this to me is really, really sad because as you guys all know, it's persisting and spilling over into vaccine attitudes more generally. But then this is the one where I wanted to show you how big of a difference you can see pre-post vaccine in the US and England and Wales mortality. So the US is in blue, and this is showing it by age, which you can also see the different age burden in the US shifted to younger ages. But I just kind of want to point out in any of these, you can see how the mortality drops so much post-vaccine for England and Wales, and the US saw, almost more excess mortality post-vaccine than pre-vaccine. And, that's just so frustrating given if you can see this as a potential counterfactual with kind of rapid rollout at the right moment. I think it was a little lucky that England vaccinated right in December, right before Omicron, but still, to me, this is a very convincing figure to show the efficacy of the vaccines, despite some continued skepticism in certain circles. So, yeah, I'll just try to summarize some of these lessons. The COVID pandemic sadly really exacerbated pre-existing health disadvantage in the US relative to the UK. and other European countries. And this was especially noticeable in the younger age composition of deaths, which I think there's a lot of different explanations, both social and underlying health vulnerabilities. I didn't even mention the very stark race ethnic differences in mortality in the US. We had a paper on that. It's harder to do that in the UK because we don't have as much race ethnicity data combined with mortality data, but we know it was really bad in the US. Then the political polarization of COVID vaccines and all the other non-pharmaceutical interventions. And England really got a bad kind of reputation within Europe as kind of the leading edge of a lot of these waves. But if I step back and look at the overall performance, they did, England did a lot better than the US, and I think did really, honestly, really well with the vaccine rollout and uptake in that regard. But I will say it was very interesting to watch the press conferences those first few months where I, would click between Donald Trump and Boris Johnson. And Boris Johnson looked like such a statesman. It was amazing. He was listening to his scientific advisors, and it was quite a contrast. And yeah, so I'm wrapping up soon because I definitely want time for questions, but my group is now thinking a lot about what's next for mortality, what kind of potential scars is COVID leaving on population trends and life expectancy. And this is in progress. We're trying to see if countries have caught up by 2024. So these are by age, and kind of getting back to that zero line means you're back to where you would be expected to be before the pandemic. And so far, the takeaway is a lot of countries have still not returned to that pre-pandemic mortality trajectory, including the US, and England and Wales are not kind of back to that line where they should be. It depends on age. And again, you can see the US doing really poorly in the younger and middle age groups. So this is something we're watching with great interest, and was talking to Dennis, kind of really want to understand, is COVID, a new risk that we're adding on top of all of our other hazards that is just going to raise kind of baseline mortality? And if so, who is most vulnerable to continue dying of COVID? These are all, yes, questions that I'm interested in. So if anyone wants to collaborate, I think there's going to be obviously kind of lagged effects and things for us to study about COVID for the rest of our careers. Many of us, we're interested in these indirect effects, what happened to disruptions in healthcare, screenings and treatments. I think that will take time to play out. Long-term impacts of just having had COVID or been seriously ill with COVID. We know being hospitalized or in the ICU can just really, tip an older person into a trajectory of frailty. A lot of great research on long COVID, but challenging research to do. I'm very interested also in just long-term impacts of infections in kids and in utero, because we're still writing papers in Demography, at least, about the 1918 flu and people who are in utero, and long-term impacts on health and cognition. And so there were some really good studies showing impacts of COVID and vaccination on preterm births using some really nice design. So we know that, having COVID increased your risk of premature birth and stillbirth, and having the vaccine reduced it. So looking for those longer term implications, I think, will be important. And then the things all of us kind of study in social determinants of health, all of the social and political and economic disruptions of the pandemic. We know education, learning loss and other educational disruptions were really, really important, and things we should, be aware of in the long term. And then, as I alluded to, I think we're all just quite frightened about this bottom point here, about what's happening in the US and potentially more broadly, but especially here with this political polarization that, masks and vaccines have suddenly become a political identity. And it's very hard then, even with just accurate information, to move people in their opinions on those things. I'm going to skip that, but just one quick shout out to the science communication folks. So as I mentioned, I was kind of pulled into this group that quickly went on social media and started answering people's questions during the pandemic. And it really converted me into believing that we should all be sharing our science more and, learning how to communicate to a more general audiences. So this was our group originally called Dear Pandemic because we were answering questions like Dear Abby. But a reader nicknamed us those nerdy girls that they would trust anything those nerdy girls said. So that name stuck, and we continue to broaden our topics. This was during the pandemic, but we continue to answer public health topics now in a variety of areas: mental health, reproductive health. We're looking for people who are interested in science communication and want to try that out. Please get in touch with me, students, researchers. We're kind of on all the platforms, but our newsletter is a good way to make sure we show up in your inbox on Substack. So yes, I'd love to talk to anyone about that more later, but that's what Rachel and I worked on together. And it's a really great effort. And I encourage more people to kind of do that kind of engagement. And I will stop there because that was a lot. And Levi, yeah. Yes, you first.
Thanks for the talk. I was wondering, why do you think, I'm unfamiliar with Eastern European health systems. So I'm wondering if there's a certain reason why, like a policy reason, I guess, number one, why their life expectancy from before COVID was already not that great. And then I guess during COVID, why it got worse.
Why it was worse. Yeah, no, great question. There was a long-standing mortality crisis after the collapse of the Soviet Union that really impacted mortality both in Russia and most of those countries. So they saw huge drops in the 90s, which have kind of recovered, but not up to kind of the levels of the top performers. So I think there's still the legacy of that. And then my understanding, which was more talking to a lot of the Eastern Europeans that I know in London, was that partially because of the Soviet era, there was big mistrust in government, which, as we could see then, so vaccines were looked upon with great skepticism, but probably similar to here, all the other interventions as well. So I think there's a big correlation with mistrust in government and the COVID pandemic outcomes. Levi.
You demonstrated that it's possible to very well adjust for age across different countries and make direct age-adjusted comparisons across different countries. So wondering if the same thing is true for SES, which, like, I was wondering if, that lagging behind an increased life expectancy in the US, like, maybe that could just be explained by differing portions, like if there are more people without high school education.
Yeah, no, it's a great point. It's not easy to do that because the US is kind of unusual in having both education and race ethnicity on death certificates, which is where a lot of this data comes from, the vital registration. There's some survey linked comparisons you could do, but to answer your question, it's not, that doesn't account for the US disadvantage, because you can look at people with the most education in the US are actually doing worse than even more disadvantaged Europeans. So that's also kind of the shocking thing, is that this kind of suppression or this falling behind in mortality is happening for even the most advantaged Americans. There are huge disparities, but it doesn't explain it. And in fact, it suggests there is something in our environment that's, holding even the most resourced and most advantaged people back from living a long time. And I have a lot to say about like what that might be, but a lot of it is this yeah. Fire safety, evidently not the problem for the US. But we know certain things like external causes, the US, drug overdose contributes a lot to this. Like the chances of dying before age 40 are many times higher in the US compared to equivalently high income countries. So there's a lot of premature mortality from guns, transportation accidents, and drugs. But then it also, the major part of it, because this is how most people die, is just slowdowns in cardiovascular disease improvements, which had been doing really well for decades. And the US is completely stagnating and even seeing increases in cardiovascular disease mortality. So that's where there's so many complex, determinants of that I think all of you could contribute to understanding if you're interested.
See the increased mortality to cardiovascular disease, cancer. It's counterintuitive that cardiovascular disease was pervasively increased during COVID compared to cancer. It really the vigilance of access to people diagnosed with cancer. The whole idea was early detection of
Right.
cancer. Very skewed perspective. I think that people diagnosed with cancer,
Yeah.
likely to die within that time period than people who cancer could have been detected.
Yes.
The delivery of care to cancer patients, maybe at a different level of vigilance and accessibility. Cardiovascular.
I think that's a good hypothesis, because you're right, kind of getting in for your cancer treatments would probably be prioritized over some, and people were also staying away. Yeah, and people were staying away. There was definitely a dynamic of people not going in for urgent care when they might have, especially early, a lot of deaths at home really, really increased during the pandemic. And so I think a lot of those also might have been coded as cardiovascular disease when they were actually COVID. But I think you're right. Like we all assumed missed screenings would show up very quickly, but that would be a longer term thing and may not show up at all if people could catch up in time. So I also do think there was some of this displacement, which cancer, people severely ill with cancer dying of COVID, and they might have died from cancer 6 months later, but they're not showing up then in those statistics. So, but I think it's an interesting question, but we saw the same cancer results in the UK with a very different healthcare system. But that's, yeah.
Because of
And immunosuppression, right. Yeah, absolutely.
Heart disease, catch-all for,
Exactly.
physician, right, that's
Yes.
usually heart failure, whichever.
A heart failure, right. Yeah,
Much attention to trying to really get it right, especially.
Exactly.
in the pandemic.
exactly. Yeah.
I mean, I know the New York City Health Department has done a lot to try and train providers on this, to try and get them, and including in their software that they use to report the cause of death, but so it might be interesting to compare.
Right.
Still bad.
No, I believe it. And the Andrew Stokes and colleagues that I mentioned have done some really interesting work on looking at coroners, like different around the country too. It differs who determines that cause of death, like whether it's an elected position. I didn't know that coroners were elected in some places versus medical examiners. So it ended up, I think, leading to a lot of undercounted COVID is how I interpret a lot of that. We also know that COVID can increase CVD risk for a while after you have it.
Would you please talk about the differences now in efforts to prevent COVID infection now, for example, testing of various sorts, masking in health settings, etc.?
Well, that's a really interesting question, because that's where I feel like the UK has diverged and very much kind of removed all precautions. And even has a very different vaccine policy now where only people 70 and over are eligible for the vaccine. Masking, yeah, I think it was in July of 21 that Boris Johnson kind of declared Independence Day, some July date in where the pandemic was over and kind of all restrictions, including any mandatory masking. So,
The statesman.
yeah, statesman, but so there's a lot of complaints within the healthcare system about lack of proper protection, and it's really being, like a lot of places here, kind of pretending that it's not there anymore. And a lot of our really good surveillance that we had, this national infection study, also got cut and is now seasonal. So I don't think the UK is a model at the moment. And my sense is in the US, it's just very heterogeneous, again, by locality, states. And so that always makes the US an interesting laboratory for understanding how different approaches work. But no, I've lost a little confidence in the UK. You know, it's great that it was not politicized, but now it's just like, it's just over and it doesn't matter. So that's not a great place to be. Mary.
The changes in life expectancy in the US and being more vulnerable, young people being more vulnerable to COVID. In that, I wonder whether there's a difference in the people who are born in the US. Because the US has much less, I believe, abortion than other places. So therefore, people who are going to live a short time.
Frailty argument.
In some places.
You should be a demographer, Mary. That's like prenatal selection. Yeah. Yeah. Yeah, it's an interesting, I mean, yeah, I know some people who work in that and kind of look at the implications of differential prenatal selection on later life outcomes. I suspect that would not be a big enough effect to show up in these huge life expectancy differences. And the US actually really benefits in overall life expectancy from high levels of immigration. So immigrants live a lot longer, and we would actually be looking worse if we didn't account for like the 15% foreign-born population. There's some nice papers showing what it would be with and without immigrants, and they're actually boosting our life expectancy. But I like the way you're thinking. So it's something to explore. Yeah, we definitely know that's higher in the US. And it's just a question of how do we know if that accounts for that? I feel like there was also differential exposure, occupational, you know, fewer I don't know, you guys tell me, like it was very socially stratified, obviously, who was not able to shield and had a lot more exposure. But it's also just possible in 2020 that more people in the US were exposed than in England, where there was more social protection. But again, it's kind of a hypothesis. I don't know how to test that well, but I think it's more the underlying health issue.
Excess deaths. I didn't focus up there, but I am curious about the diabetes excess.
Yeah, I think our hunch, I mean, is also this kind of misattributed COVID, because it's in that category of it kind of followed the same pattern of COVID, the COVID waves. Okay, let's hear.
Very clear. What's triggering?
Yeah, yeah.
Very true. I myself
Yeah,
sharing. I did some post-COVID.
yeah. And I think, yeah.
Very real thing.
No, I believe that. And yeah, Exactly. And I think
Yeah.
that it's harder to see then because it's a more like distributed thing, but that's what we're trying to do is like, how much does it coincide with these COVID peaks, or do we see it kind of trailing off later, which would point to more of that mechanism. So
Which, how uncontrolled your diabetes was, how long you had it.
yes, which, yeah, if we can think of the right data to look at that, a lot of these healthcare record data sets like the veterans ones have been really overused, I think. But in the UK, like we have a lot of health record data where it covers like a lot of the population. So you worry a little less about these specialized veterans, and we've done some nice things looking, yes, at long-term effects if you got infected before or after the vaccine era. And so you can kind of play around with the timing maybe of the variants as well in that type of data.
Diabetes. Effects of that. Post-acute sequelae.
No, it's such a strong interaction somewhere there. It's really interesting.
Your thoughts on the differences in the uptake of the third dose of vaccine between the US and the UK. What was done logistically in the UK to accelerate the uptick? And what was considered essential along the first two in the UK, but not in the US?
Yeah, that's a great question. I mean, I think part of it was logistical with the healthcare systems, but that third dose, if I'm remembering here in the US, because we were trying to get the message out, it was strongly recommended that everyone get it, but I don't think there was an urgency to it. So for whatever reason, the message just didn't get out. And I think like the anti kind of vax sentiment had already pervaded a bit. So there was kind of a skepticism of, oh, do I really need a third one? You told me that these first two were, going to be amazing. So I think it kind of goes back to the attitudes about vaccines, and then the practical side of the rollout in the UK. They set up these big, in stadiums and health centers, but very close to everyone. It wasn't hard to go get your vaccine, and you just got a message. They even did trials of which text messages would get the best turnout. But I guess people were just very accustomed of, that's how you would get a notification from the NHS about anything. And it just made it very easy. And I'm trying to remember if there were any other it was Christmas. It's like, we're going to do it by Christmas. Save Christmas. Yeah.
Kids vaccine.
Oh, that's when the kids were getting approved. Yeah.
If I was gonna say if there was a trade-off, they were like, well, that's the population.
Right. Yeah, you're right. That was like the fall that all of the vaccines came out. But it's been very similar for all the boosters. Like the take-up is like 30%. I don't know, it's quite low. And so that was kind of the first round of that seemingly more optional post, and it's just stayed really low.
New York City had like.
Right.
the NYC where you couldn't go into a restaurant without, I think it was.
And then they didn't
first
do
or-
that for the third. For the third dose, it wasn't. We didn't have as much of that. It was discussed, but there wasn't as much mandates.
There's any, if the third, like when you apply for a job or something, it says like primary series, right? Or you go to, I think I saw something for the Emmys that came out on X that said like they did test all of them. It's like the 1% is being COVID cautious, right?
Right.
And then they also had to have just their primary, but not necessarily like the Novavax updated.
Yeah, I'm surprised there's any requirements anymore.
Yeah.
Yeah.
But my question is, are there public health ethicists on these advisory boards in like health communications for vaccines? Because it seems like
I don't think so.
question not only for like health comm specialists in public health, but specifically for ethicists.
I agree. I think on that National Academy panel where they tried to come up with consensus on vaccine prioritization, it was, all of those groups were included. But then the actual committee, vaccine committees, they've been standing committees for a long time. And my understanding is it's very dominated by clinicians. So I don't have inroads into that world, but I bet Ayman does. So I think there should be more representation.
Be a change, major things that was consensus on. And we have a health communicator here, so I'm speaking out of turn, was that there needs to be a change in the mechanism for health communication, the prioritization of health communication, the training in health. You're absolutely right. And I don't think, unfortunately, we always deal with a crisis. Once the crisis is over, forget the wisdom that we earned during that crisis.
But I don't think they had communication people on these committees because part of the challenge was trying to explain to the public later what it all meant. But did you have thoughts? Thanks. Okay.
Second vaccine, third vaccine, the Oxford AstraZeneca vaccine was there. There was a vaccine deficiency in continental Europe.
Yes.
How does that play in? We're doing all this broad measurement.
Trying to get it more nuanced. Yeah. I know. Sputnik, yeah. I think that's a great question. I have not seen a lot of aggregated data. Like it's very much just, proportion of the population with 1 dose, 2 dose. I think there's probably in each country, I bet you could get more nuanced data, but it would be a very complicated analysis, I think, to try to tease that out. China is an interesting example too, because they really delayed, obviously, mass infection, but didn't seem that protected from their own vaccine. Although I guess we might not quite ever know the scale of that. So it might require, looking for some special circumstances where a country exclusively had one type and then the timing of when they got hit. But I think we should try to learn from that. And you're right, it's very broad strokes and kind of this national level data.
Trusting of the messenger is in getting vaccinated. And I'm just an American, I'm making a guess, but I think people trust the NHS.
Yeah, yes, people have pride in the NHS. Yeah.
We didn't trust the CDC at all.
No.
Yeah.
We don't have that.
I know, I
think that's probably a big, and just general trust in governments.
Yes. Yeah, I agree. And that's what makes it hard to think about how we can improve upon that.
Hard to bring an end to such interesting conversation, but it's really a good sign that we have a wonderful speaker. Thank you for such a great presentation.
Thank
It's
you
hard
guys
for
for
us
the
to tear
discussion.
ourselves away from you.
We can
but
keep, we can keep our therapy session.
Thank you all for participating.